I'd like to introduce our panel that's going to share with us this morning as we talk about this very pertinent and important topic. First, I would like to introduce Sue Anderson. She is the National Director of Emergency Management, Environment of Care, and Safety with MedXL Facility Management. Next, I'd like to introduce Kathy Tolomeo. She is the Director of Compliance, Strategies, Safety, Security, and Emergency Management with JLL Healthcare Solutions. David Sine is the Chief Risk Officer, Officer of Quality, Safety, and Value with the Veterans Health Administration. And Catherine Petrovic is the Senior Associate Director of the Standards Interpretation Group with the Joint Commission. Well, the last year certainly has been interesting, hasn't it?
For sure. Slightly.
With, as we look at the needs of behavioral health patients or those that have behavioral health needs. And we've placed a lot of emphasis on that. There have been a lot of risk assessments that have taken place. There has been a lot of money spent that probably has really benefited behavioral health patients. There has been a tremendous amount of money spent that was probably wasted because there are a lot of misconceptions about what is required and what do we need to do in terms of providing spaces to treat people that have behavioral health needs. And there's really two very different kind of environments. A behavioral health hospital or a space that is designated as behavioral health. Maybe in a community or an acute care hospital, a behavioral health unit. And then there's just the hospital, just a typical hospital that treats typical patients. And I think sometimes the requirements and the needs have been confused a little bit amongst the two. So our hope this morning is to really talk about what is needed, what is a true risk assessment, what is required where, what do we need to be focusing on, and perhaps to dispel some of those myths. Our panelists will each spend some time talking about various aspects of this issue, and then we're going to open the floor to questions. So as we are going through, if you have questions, please feel free to step up to one of the microphones, and we'll do the question and answer portion at the end, and I'll watch for you to step up and do that. But we invite you to share your questions. I will also mention a couple of resources, and we have some resources listed in a bit, but several of the accrediting organizations have a space out here in the convention center, and they have hours where they're going to be there. Stop and talk to them. Talk to them about the real issues. Make use of the resources here as we try to do the right thing, but not waste money on something when we have so many other healthcare needs. So we're going to dive in. And Dave, I wonder if you would just share with us, what are the definitions? What are we talking about here?
Oh, thanks, Tim. When the Joint Commission expert panel met, one of the first things we had to address was, well, when everybody's using this word ligature, or ligature risk, what is a ligature? And so we searched the internet. That's always a great place to start. And so we have two definitions to share with you this morning. The first one is the CMS definition, and you can see it up here, I think. We'll get the slide up. And it says basically a ligature risk is defined as anything which could be used to attach a cord, rope, or other material for the purpose of hanging or strangulation. Ligature points include shower rails, coat hooks, pipes and radiators, bedsteads, window and door frames, ceiling fittings, handles, hinges, and closures. Well, not to be outdone, the expert panel and the Joint Commission worked to come up with their own. I like this one a little bit better, but you be the judge. You can go either way with this. And the Joint Commission decided that they would use the term ligature resistant rather than ligature free because they did not think it possible, and I agree with this strongly. You can't remove all the potential ligature points that have even a remote chance of being successfully used in a suicide attempt. So with respect to elements to the physical environment, the panel adopted this definition, and it is without points where a cord, rope, bed sheet, or other fabric or material can be looped or tied to create a sustainable point of attachment that may result in self-harm or loss of life. So the difference there is the sustainable point, because there are items that are breakaway, so this gives you a little bit more latitude. The other thing about the definition I just read from the Joint Commission, it's also going to be blended into the FGI glossary, so you'll find it in 2 places.
David, would you share a little bit also with us about just some statistics about the issues that we are dealing with?
Yeah, you can't do a program on suicide without talking about statistics, so this is the most boring part of the presentation today. There's a wide range of suicide rates, but a few of these statistics should hit home with facilities people. Between 5 and 80 per 100,000 psychiatric admissions in the United States. An estimated 12 to 25 attempted suicides for every suicide death. That's a good statistic to remember. So this is going on all the time, then it's in our face, so to speak, when there's success. Joint Commission review of inpatient suicides found that 75% involved hanging, and another 20% resulted from patients jumping from a roof or a window. Parking garages were part of that study as well. That took place in 2008. Another study within Veterans Administration facilities found that 52% happen on inpatient psychiatric units, 31.4%. The method was hanging followed by jumping. And here's one, 41% of the hangings were from doors and cabinets, and then bedding was the ligature that was used 40% of the time. This last piece I want to put an emphasis on as well, because there's a myth out there that there's some safe zone below a certain height. You don't have to worry about an attachment point. This kind of makes that myth go away. A separate study showed that 50% of the hangings had attachment points below waist level, so there is no safe zone. And with that, I think we turn it over to Sue.
Right. Yeah, Sue, would you want to share with us about risk assessment? Really kind of 2 different areas, behavioral health, non-behavioral health.
It really does. And the first thing that we have to remember is that a risk assessment is what drives every process in this. So I want you to take a look here, and we're going to give you a definition of what's the difference between a designated behavioral health area and a non-designated. So first off, we need to look at what is a designated area. That's going to be a behavioral health hospital, an inpatient behavioral health unit in an acute care hospital, or non-behavioral health units that have safe rooms. So we're not talking about areas like the ICU. We're talking about your inpatient units. So it's going to start with the risk assessment. We're going to look at what our population of patient needs are. We're going to look at the whole area as a whole. And you need to have a group of people, not just one person going through and doing this. You need to have a multidisciplinary group that's going to go and take a look at all the different aspects. You look at the risks, decide if we have to have corrections or if there's exemptions for them. It may be changing policy or changing procedures, so it's not necessarily going to be something in the environment. And then the big part of that is to make sure that your staff is very well educated and able to speak to those policies and procedures. And then you have to circle back and you have to make sure that those mitigations are actually working. And if they're not, you have to put a corrective action in place. Next one. So now we'll talk about the non-designated one, and this is where a lot of people have gotten very confused. Now I want you to think about the rest of the hospital. These are temporary locations where you may be taking care of behavioral health patients. Think about labor and delivery units, maybe someone in the ICU or the emergency department. The important point is this still starts with a risk assessment. Everything is driven from this risk assessment. And you still do the same multidisciplinary process, but what you're going to do is look at things that you can change temporarily. You'll see here it talks about removing physical risks that should be assessed and taken out of the environment if not required. So we're not going to leave in an IV pole. We're going to take that out for that behavioral health patient if it's not necessary at the time. We're still going to have the same policies and procedures, and we're still going to close that loop the same way we would with an inpatient unit.
Kathy, would you share with us just a little bit about scoring and how that affects these areas?
Sure, no problem. So scoring, there's basically 3 different areas that you could be scored related to the ligature. First and foremost is going to be your physical environment. This has to do with the design features that are going to pose as a ligature risk. Now, there are a lot of resources out there that you can be utilizing to bring in ligature-resistant products into your environment. Please, I cannot stress enough, when you look at these products, you still need to do a risk assessment on those products. Because again, it's ligature-resistant. Doesn't mean it's 100% ligature-free. And so you need to be aware that this is the best product for your environment, for your unique facility, and identify how it still may have risk, but you've minimized that risk, you've lowered that risk down. So again, even though you're going to do your initial risk assessment, you still want to continue to do those risk assessments. So if you don't have that documented, usually I would recommend, because this is a high-risk situation, that you should be at least doing this on an annual, if not semi-annual basis in reassessing. And so again, that lack of a current risk assessment, don't hand something to the surveyors that is 5 years old. Don't hand something in which you're not showing timely corrective action. You need to show that you're on top of it. Just like when you manage the statement of conditions, you have to manage this with equal amount of time and emphasis within your organization. The next place that can be scored, and I don't think the expert panel can emphasize enough, this is a collaborative team approach. If one team is not doing something, it can negatively impact the other team as well, okay? This is a facilities physical environment with clinical working together very closely on this. Because if clinical is not doing their part, you may have identified all of the risks, but now if mitigation or staff education is not happening in these areas, they're not doing what their policies and procedures say, that can impact and also lead to potential a condition level finding or even immediate threat to health or safety, immediate threat to life situation. Lack, again, of that appropriate mitigation, lack of providing suicide prevention information to an individual at risk for suicide upon discharge to his or her family, and Catherine will talk a little bit more towards the end as to some of those clinical strategies. Also through scoring is leadership. We are going to, leadership needs to be responsible, and they need to provide the support, the resources, the time, and take it very seriously. And so if we don't see, if that leadership support is not seen there, there can definitely be some scoring for the lack, again, of that timely corrective action, holding staff accountable, and not providing those resources.
So for behavioral health, how do we design those spaces? And David, you have just a fascinating story about this. I'd like you to, if you would share with us about these two rooms.
Yeah, thank you, Tim. This is actually one of my favorite slides. And for those of you who are in the room, you may have heard this home-like environment buzzword that's in behavior health design right now. Everybody is telling us as designers, engineers, and architects, I want to construct a home-like environment for my patients. Well, the first problem I have with that is, I guarantee you, your home doesn't look like my home, and neither one of our homes look like a yurt. So when you say home-like, this shifts around a lot depending on who is speaking. So this is one of my favorite slides because I have two pictures up here for you to look at. One is of an award-winning, purpose-built, locked adult behavioral health unit in the northern United States. The other one is of a Holiday Inn Express. Can you tell the difference? You can stare at this a long time, and eventually you might spot the telephone on the nightstand, and that's the Holiday Inn Express. But look at the other one. For you, that's the one on the right. Look at that chair. How on earth did this facility get away with putting a chair like that in a behavioral health unit? Most of us look at that and say, oh no, that's got a ligature attachment point. The way they can do this is because they did a really solid risk assessment of their patients, and they can tolerate this much risk on that unit. So that's an important slide and a very important concept.
So for behavioral health spaces, Kathy, would you want to share a little bit more about design and how we approach that?
Sure. And this time I have my mic on. Sorry, I had it off. I'm having a bad bronchitis day, so I didn't want to keep coughing into the microphone, so I apologize. There I go. So when we start and we look at design, again, as Sue mentioned earlier, we really need to make sure we know what space we're talking about. And looking at our designated versus our non-designated environments and what are those requirements. So typically when people go to do risk assessments, they'll ask, what type of risk assessment should I be using for my non-designated? I tell them use the same thing that you would be using for your designated, but here it's just about identifying those risks. But either way, again, we want to look at our designated behavioral health. There is a difference, as we were talking earlier, that you may have a space that we call a preferred room. A preferred room is still truly a non-designated space. We usually see this in the emergency department. You have an influx, you have a high population maybe of behavioral health patients coming into your organization. At time of design, you are not required to have a designated behavioral health space, but you want to try to minimize some of those risks. So we see the garage doors utilized quite a bit to kind of close and lock off that head wall to minimize the risk when you do place a patient in there. But it's still a dual purpose room. I can still have the capability of treating somebody of non-behavioral healthcare needs in that room. So again, when you do that, it's still, you want to identify the risk, it's a preferred space, but it does not need to meet all of the requirements of a designated behavioral health environment. So make sure you understand those differences in your design perspective. Next as well, I always like to remind organizations of Joint Commission's standard EC 02, 06, 05, EP1 that the requirements of how we look at our design. So first and foremost, you need to follow all of your state rules and regulations. If those are silent, then we go to the 2014 FGI guidelines. If those are silent, then we start looking at our evidence-based guidelines. So here are some examples and some resources that are out there that you can utilize when you're doing your risk assessment of your behavioral health care environment and what is considered best practice. And there's a lot of different tools out there. They are very similar in nature, but they can at least give you the information that you need.
We talk a lot about risk assessment of patients, risk assessment of space. David, would you share with us a little bit about how do you do a risk assessment? What is that? What is involved? What's a methodology?
Yeah, good point, Tim. I think we've used the word risk assessment about 25 times so far. Maybe we ought to actually see what one looks like. And it starts with a 150-year-old definition of what is risk. And for risk managers and people in the insurance biz and people in high-risk occupation, risk equals frequency times severity. So here's what's known as a heat map or a risk map, and basically you're multiplying frequency times severity and then graphically expressing it. So I have frequency or likelihood on that vertical axis on the left-hand side, and I have severity or impact across the bottom. Where these two things intersect in the upper right-hand corner or quadrant, that's where the highest risk is. So that vertical axis on the next slide, Tim, it gets a little tricky if you're not a clinician. And this is what clinicians think about when they talk about that risk vertical axis. Is you start down with suicidal ideation, and it works its way on up through self-directed violence, and ultimately ends up at suicidal or self-directed violence. It's good to get everybody on the same page when you're talking about risk, and this is one of the tools you can use in your facility to get them there. So if I take that same concept of risk equals frequency times severity, and I study 150 suicide incident reports, I end up with the next slide, which is this. So what you find in suicides is you need two things. You need from the patient intent for self-harm, and that's extremely hard to estimate, but I put that on my vertical axis. And then across the bottom, I'm going to put opportunity. What we find, again, 150 investigations, is suicides don't happen in public spaces like here. They happen privately. They happen alone. So within our hospitals, we start to get the most worried about bedrooms and bathrooms. So here's a way to do a risk assessment in your facility, no matter what the room use is. What's my patient population or my individual patient looking like? That's on the vertical axis. And across the bottom, then, I've got the opportunity. So it doesn't matter what type of therapy we're talking about. You could come to me and say, I need to do a risk assessment for a new modality of treatment in my hospital. We're going to do moonbeam therapy. Ever heard of it? It's the hottest thing. And what you, as the designer, architect, and engineer, then have to say to the clinician is, tell me about your patients. Where do they place on that vertical scale of intent? Do people getting moonbeam therapy, are they suicidal? Oh, no, not at all. Quite the opposite. Interesting. In the moonbeam therapy room, will they be alone or always with someone like a therapist? Oh, they're always accompanied. Now you know where to place them on this risk assessment tool.
Let's talk a little bit more then about design of those areas we've determined are going to be behavioral health units, whether they be in a behavioral health hospital or in a general hospital setting, but designated behavioral health.
So this area is where we've gotten confused recently. And so we're going to give you some real general guidelines to help guide you. When we're talking about inpatient behavioral health units, remember that's our designated areas. So whether that's in a behavioral health hospital or if it's in a unit in an acute care hospital, there are some areas that must be ligature resistant. So remember, you start with your ligature risk assessment. Your patient rooms must be ligature resistant, that whole area, the patient bathrooms, the corridors. That doesn't mean that you have to make changes completely to the physical environment. There are other options you can do, and we'll talk more about that. But common areas have to be done as well. There are some exceptions. If you've identified your risk and the staff is educated, remember I keep going back to staff education. That is so important that they can talk about those risks and what they've done to mitigate them, and being able to verbalize that. They have to have direct, continuous observation by staff. So again, when we were talking about the moonbeam therapy, I like that analogy. When we're talking about that moonbeam therapy, if they're with that patient all the time, we have some exemptions. And then self-locking and self-closing doors. But it's important to remember that for an exception to be in place, all 4 of those items must be able to be checked off, that yes, all 4 of those things are in place.
David, I know you have a fascination with ceilings, as we've been talking.
I get a lot of phone calls about ceilings, and in fact, one of the drivers of the Joint Commission expert panel was what to do about ceilings. And Kathy and I have got a story I'll share with you later about ceilings and Joint Commission surveyors. But ceilings, basically, in the patient room and bathroom, within the patient room, must be solid and hopefully even monolithic. In the corridor, drop ceilings are permissible when visible from a 24/7 nurse's station. And there should be no objects in this area that the patients can climb on or use as an attachment point. When not visible, other mitigations are acceptable, and Sue will talk a little bit about those as well. Other patient accessible areas, there are some exemptions for common areas. We'll talk about that. And again, there are mitigation suggestions that we can share with you.
Mm-hmm. But again, we're talking about behavioral health. Not every patient room in an acute care hospital. I think that's where some of the confusion has come in just a general hospital setting, do we need monolithic ceilings? Do we need to do all this? No, we don't. Mm-mm. But it's confusing the two. So we want to be very clear, we're talking about behavioral health, designated behavioral health. What about the doors when we're talking about behavioral health?
Sure. So there's lots of different types of doors that are out there. Obviously, there are door sets such as your fire barrier doors, your smoke barrier doors that are required by code to have particular hardware. They have to be full-size doors. We can't modify those things. Even the corridor doors within the patient room, you have the bathroom doors as well. Keep in mind, and we'll talk about this a little bit more, we don't want to create another safety issue or problem or even a code issue with the solutions that we come up with. So doors has definitely been a challenge for a lot of different organizations, some of them trying to make modifications to them. The risk really with doors is not only barricading themselves within the space, but we're seeing more and more of the patients utilizing those doors also to hang themselves from, utilizing the different type of hardware, the hinges, the top of the door. I've even had conversations where patients utilized a ligature-resistant door handle with a piece of 1 inch, a pipe that was plumbing from the toilet that was only 1 inch off the floor. And so they were successful in making a connection. So when you look at your environment, look at it as a whole with your solutions. Look at your hardware. There's a lot of different solutions out there. Again, none of them are probably going to be perfect, but we do include all the things from Again, the door handles, the hinges, the latches, the locks that you need to be looking at for those risks with the doors. As I mentioned, these are just a couple of pictures of things within the physical environment. We talked a lot about the door handles already. Please, when you install these things, make sure you are installing per manufacturer's instructions. If you don't appropriately install them, you could be adding a ligature risk into your environment. We see this a lot probably with the doors with the hinges the most, as well as then organizations trying to cut the doors down on an angle. And they have to remember, you might be cutting it down on an angle, but if that latching mechanism is still there, you still may be able to wedge a sheet in there and still be successful in creating a ligature point. So you have to look at the whole assembly. Exposed plumbing, the toilets we know was a hot topic in the beginning on toilet seats, sinks, showers, all the different fixtures out there, even the toilet paper dispensers, paper towels, how you manage linen within your space, the handrails. The handrails is something that I see where organizations make a mistake, where they'll try to modify a non-ligature resistant handrail on their own. Well, then you might be making an ADA code violation because there's a certain grip that you need to be able to have. So be careful when you try to fix these internally versus purchasing a ligature resistant product that's out there. Again, look at your signs, things that are mounted on the wall. I do it on my risk assessment basically from the top all the way down, utilizing those evidence-based guidelines.
So you mentioned something a minute ago as we're talking about, again, designated behavioral health spaces, behavioral health hospitals, behavioral health units in acute care hospitals, and that we have to be ligature resistant, but there are some exemptions or exceptions. Not really exceptions, it's other ways of achieving the safe environment. Or if you could share a little bit about that.
Absolutely. So when you think about the environment as a whole, and think about the hallway, I'll use that as my example. These are some of those common common patient areas that have to still meet the ligature resistance, but they have some exemptions that come into play. Again, it all starts with that risk assessment. So you're going to look at your risk, you're identifying your risks. They have to be under direct, continuous observation. Now, I've had a few people ask me recently, what exactly does that mean? And I know we're still really working out what the definition of that is. But one thing I know that it's not having a camera that simply records everything that happens. All that is a record of what happens. It's not actually observation. So you have to have a human being able to observe everything that's going on in that area. Again, the self-locking, self-closing doors. And once again, I'm going to say it, staff education. They need to be able to speak to what the processes are and that they can see and why these exemptions are in place. And then another important one that we forget about sometimes is the medical needs of the patient. And I'm going to share with you an example that I experienced. In the beginning of this whole process, where everyone was worried about the medical beds that they had in place. And this was in a geri psych unit. And they were hurrying up and trying to figure out how they were going to put pedestal beds in. Well, now the average age of their patient was 86. And they also had some other type of medical issues going on along with the psychiatric needs. So imagine what would happen if you were having 86 and 90-year-old people in a pedestal bed. Now we're going to have broken hips and all kinds of other things happening. So you have to take in the medical needs of your patient. You're still doing a risk assessment. You're identifying why they need to have something different. You're documenting it in the medical record. Kathy talked about how this is a joint effort. We have clinical and the physical environment coming together. This is a great example. There's that staff education again. And then making sure it's appropriate and monitoring that and keep closing that loop and checking to make sure that we're doing the right thing for the patient.
Kathy, would you want to carry on a little bit with this conversation?
Yes, no problem. We're also going to have some other exemptions. There are going to be certain features in your environment that are needed for security purposes. It is a behavioral health care unit. You may have a locking arrangement with even a mechanism maybe installed on the wall where you have to put the key in order to get out the door. We know the code allows for these types of things in the behavioral health care units. And that little mechanism may not be ligature resistant, but you have a need for it in that environment for security purposes. We can't eliminate it. There may not be a better product out there to be able to put in that type of situation. There also might be safety. I know shower curtains has been a very hot topic. But we don't want people taking shower curtains down if the water is going to splash out, go on the floor, and now I have a slip fall risk. As well as CMS, I don't believe really expects that you have to gut the whole bathroom just to be able to eliminate that particular risk within the environment. There is some level of reasonability within some of the corrective action. And then finally, I know I touched on this a little bit with the doors, we have our codes and regulations. The top ones that I tend to see are life safety code, your fire barrier doors, your smoke barrier doors, your corridor doors. You can't remove, the exit signs. You have to have the strobes. You have to have fire extinguishers. Now, there are certain things that you can do to improve the safety and not have those things necessarily be a risk for those patients. But those are things that you have to keep in your environment. Still have to identify them in the risk assessment. You still have to document the life safety code or the ADA requirement, whatever it might be, within your risk assessment. And then, as we mentioned before, staff need to be able to articulate this. If staff aren't educated, they can't appropriately mitigate the situation. And that is so key in all of this. Staff-only areas, if they, for instance, a nurse's station, if it's a restricted area, patients cannot just wander into the space, and it is monitored and staffed 24/7, then those types of areas are not expected to be ligature resistant. And as we mentioned, the good old toilet seats, that was a hot topic in the very beginning of all of this. It has been articulated that they will not be, the different accreditation organizations will not be scoring that.
David, you've put together a interesting risk assessment or a way to assess a space and for inpatient behavioral health ligature decisions. What if you'd walk us through this?
Yeah, this was actually a result of an interesting thing happened. I was honored to be asked to go to the Joint Commission and help train their surveyors last January on how to do risk assessments. And after that presentation, Kathy and I were sitting outside of the big room, and about 4 or maybe 5 surveyors came up to us in a row and asked pretty much the same question. It all had to do with ceilings, and they asked really good questions, and Kathy gave really good answers, and I listened to this, and it was the same thing over again. Good question, good answer, good question, good answer. And I turned to Kathy and said, I'm listening to this, and it sounds like a great opportunity for a decision support tool. Let's work on one together. So what you see before you is the work product of the Veterans Health Administration and the Joint Commission coming together and saying, could we come up with a decision support tool to try to help people understand the answer to this ceiling question? So it starts with a couple of pieces here. You have to know the difference between the words should and shall. And if you're a code geek like I am, and you work with NFPA or the FGI, you know that difference. You know the difference between you should eat your vegetables and you shall eat your vegetables. So let's start with that. And then let's walk through this right now. Right now, in this room, are we in a corridor, yes or no? No, we're not in a corridor. Okay, you passed the first test. Are we in a patient bedroom or a bathroom right now? No. Pass the second test. That gets us down to this question. Are we in an activity room? Yes, we are in an activity room. Is this room occupied or locked when not in use? In other words, could a patient get in here without our knowledge and get up to some mischief? So if we're either not in here with the patient, we have to have doors that automatically close and lock. So is the room occupied or locked when not in use? Either answer will do here. Let's say no, just for fun. And that takes us over to the first use of the shall word. There shall be a solid ceiling or non-removable tile lay-in and not accessible via climbing or objects. Simple enough, right? We answered the what kind of ceiling goes in here question. If the answer had been yes, then we say it should be a solid ceiling or a non-removable tile lay-in ceiling. So we're distributing this via the VA to all of our people, so when they have conversations as clinicians with their engineers or vice versa, they can walk through this together and make some informed decisions to get them pointed in the right direction as far as what kind of ceiling should be in this room.
So far, some of the things we've talked about, there are some references listed. This presentation will be posted and you can get it from your app later today. So we won't run through all of these at this point, but there are some resources out there, as well as a couple of things that will be on your app that you can download. Catherine, we've let you be very quiet so far. I wonder if you would share with us a little bit about clinical mitigation and the Joint Commission perspective on this.
Sure, Tim. Thank you. So again, my name is Catherine Petrovic, here representing the Joint Commission. I transferred into a field director role as of April for our behavioral health care and hospital programs, and it's truly a pleasure being here today, so thank you. So here's my disclaimer. I do not endorse any companies, products, or services that have just been discussed.
Dang.
So when it comes to clinical mitigation, it really starts with leadership. And leadership establishing those policies and procedures for our staff to follow. And when the Joint Commission goes out and surveys, we're going to ask to see your policies on suicide risk assessment. How often are you doing it? In what areas are you doing it? What tool are you using? The interventions and level, to include the level of observation that you have in place based on that level of risk. If you use medical equipment because of the medical needs of patients on those designated inpatient behavioral health units, how do you protect that patient from that risk while that equipment is being used? And that includes medical beds. And then items to be removed from those non-designated areas, so such as emergency departments, when there's not in a designated safe room. What items can be removed and should be removed from that room? Or if a behavioral health patient who's at risk for suicide needs medical treatment on an inpatient med-surg unit. Again, establishing those policies and procedures for our staff so that there's no guesswork. And one of the important aspects of protecting our patients as well is, what do you do with visitors? So what we have found is often on the inpatient psychiatric units, we have good visitor policies, right? Talks about contraband, talks about policies and procedures. But what are you doing on your med-surg units where there is more of a free access? You're not behind locked doors where you're greeting every visitor. It's important to look at that. When we've looked at events at the Joint Commission, there have been serious events that have occurred from visitors bringing in items that can be harmful to patients on those med-surgical units. And again, how does then the organization manage those policies and procedures? So suicide risk assessment. I am a member of our Joint Commission expert panel. And as you know, the focus has been on these environmental issues. As we move forward, we're going to continue to look at suicide risk assessment in general. National Patient Safety Goal 15 is a very important standard of ours, and it is currently under review. We're hoping that within the next 6 or 12 months that we will be releasing the revised National Patient Safety Goal 15. So a comprehensive assessment. Could you go back to, sorry.
Yeah, could you take us back one slide, please?
So for the National Patient Safety Goal 15, again, we're looking for a comprehensive assessment. So it's those factors that increase and decrease the risk of suicide for our patients. And then once you have those factors, how are you synthesizing that information to determine the level of risk? And then determining those interventions, again, based on that level of risk. And documenting that rationale. And that's an important piece, that when we go out and survey, we need to see that documented rationale. Using those evidence-based tools and suicide risk assessments that are out there, that's your rationale, right? So you do the assessment, you follow the guidelines to determine that level of risk, and then you determine those interventions. So that is your rationale. If you're not using one of those standardized tools, then you need to document how are you coming up with these interventions for the patient. For monitoring, this is very important to make sure that you, again, are defining how you are monitoring your patients and those different levels of monitoring. For high risk, we are looking for continuous, uninterrupted, with the ability to immediately intervene. So again, how are you protecting those high-risk patients? So you have to be able to immediately intervene if self-harm is occurring. Next slide. And the staff requirements, again, for our human resources. What are you doing to train your staff? And I know Sue talked about that. So it starts with orientation and training, and then the ongoing training. And I want to be real clear, and something that we have found has been a discrepancy when we go out to organizations. Training and competency assessment are two different things. Training is providing the information to staff to give the why behind it. Demonstrated competency is making sure that you are assessing that staff are performing those tasks correctly. Okay, so that's very important. And again, that's under our HR standards. Demonstrated competency, where do we want to see this? Suicide risk assessments. The interventions. So once staff determine, again, that level of risk, are they implementing the appropriate interventions per policy? And then those modifications to the environment. So these are on the non-designated areas. Are they accurately removing those items that can be removed and documenting such appropriately? We are in the process right now at the Joint Commission of looking at the last year's data. So when organizations have been cited for these deficiencies, we're in the process, and I just currently went through 1,800 evidence of standards compliance to look for those trends, again, in order to help guide organizations in this process. And I will tell you that overwhelmingly, one of the factors that organizations have identified when they're looking at doing that preventative analysis, how did this happen? It was lack of staff education. Part of the education should also be those risk assessments. That cannot be done, the environmental risk assessments cannot be done in a silo. So again, Kathy talked about interdisciplinary, having those done by an interdisciplinary team. Is staff aware of the risks that are in their environment right now? So that's what we look at as well. Patient safety events. So how are you collecting those events? And we're not just talking about sentinel events. We're talking about self-harm events, attempted self-harm events. Those are the events that you need to analyze and look at, so that will help guide you as well in your risk assessment to know what risks are out there. What are the patients using for self-harm? How are you analyzing those? And then what corrective action have you done in order to protect patients? And then again, making sure that that's part of your overall quality assurance and performance improvement program. In looking at, again, those evidence of standard compliance that I'm looking at right now, one of the factors, and I appreciate this transparency, is that organizations have identified that those suicide risk strategies, they didn't incorporate that throughout their organization. And so that's one of the pieces, for organizations to look at.
Thank you very much for sharing with us that perspective. ASHE is going to be putting out some further guidance and information, because this is a hot topic. I would imagine almost every person in this room has been dealing with this in one way or another. And we hear the discussion about I'm spending all this money, and sometimes it really is probably not spent in areas that it doesn't need to be. We're kind of looking at this in 3 easy steps. Step 1, identify patients that are risk for intentional harm to themselves or others. If you are in a psychiatric unit or an acute care hospital that has a psychiatric in it or a designated psychiatric space, you skip to step 3. So we'll get to that one in just a minute. But identify the patient, the risk to the patient. If it is based on patient need that it is required, one-to-one monitoring with continuous observation. And again, there'll be hopefully some further guidance as to exactly what that means that is coming. So if you have a patient that admits or comes into an emergency department in a hospital and has, as David discussed, the ideation toward suicide and the means to do that, we have to, if we don't have that space, that behavioral health space to treat them in, then we can use this to do this. So this means in a hospital, we're not going to go in and make every room ligature resistant in our building. That's impossible. That's a huge cost. We have to use some other method. As we've talked about, take things out of the environment that we can and use monitoring of that patient to be able to then provide the safety for them and for others. Now remember, step 1, if it is behavioral health hospital, if it is a designated behavioral health unit in a hospital, if it is a behavioral health designated space that we want to be able to put a patient in there and leave them in there that has suicidal tendency, that we have identified that they are at risk, then we mitigate. And where we cannot mitigate, we have to do one-on-one monitoring. Where we can, we go in and make that or assess the risk for ligature attachment and those type of things, and we correct those. So here's where I think the real differentiation is this a designated behavioral health space? We assess the physical environment. If this is not, we assess what can we do when we bring that patient in, but we may have to use the monitoring because we're not going to try to make our entire hospitals that are not behavioral health a completely ligature resistant space. There's a statement that came out of our discussions here. There is no such thing as ligature free. There's ligature resistant, but there's not ligature free. We will not be able to eliminate every risk in every environment. But we assess, we look, we continually look. Don't just say, we built this to be behavioral health, it'll be good for the next 20 years. I think one of you said, come back more often, come back and assess again. Take another look, another set of eyes. We're going to open up for just a moment for some questions, and if folks would want to step to the mics, and I'm just going to kind of lead off. I've got an emergency department in a hospital. Do I have to make that ligature resistant?
I can start off with that, I guess. No, you do not. It's, as we mentioned earlier in the slide deck, when we look at our design, it's based on time of design. Now, there's been some bending of that rule recently with the behavioral health because a lot of organizations out there were used to defending it, saying, well, this was not required at time of design. Guidelines have never been something historically that you have to be compliant with the most current set of guidelines. Again, this has been something bending that rule. But in the ED, if you were not required at time of design to have designated behavioral health space, then we would not expect that to be ligature resistant. But you still have to do the risk assessment. You still have to identify the risks, especially when you're creating that list, what is removable in the environment that's a risk and what is not removable. And if it's removable, when you go to put a behavioral health patient in there, you've got to give guidance to the staff as to what are those things that they need to be thinking about. Is it medically needed for the patient? If not, you're bringing that out of the space. And again, that is a very key point, but then they need to know what are the other items that cannot be removed. So whoever is doing that monitoring, whether one-on-one or from a nurse's station, that they know what risks are in the environment so that they can appropriately mitigate the situation.
All right, thanks.
At this point in time, I am not aware of any integrated technologies that they've been looking into. That would be definitely some information. The challenge, and Catherine can probably speak to it more officially on behalf of Joint Commission, is that, Joint Commission cannot endorse any products, as Catherine had in her disclaimer. And so I think helping organizations, and if that can help minimize the risk, that's definitely an opportunity out there that would need to be shared with organizations. There are different organizations out there. Obviously, sharing these types of things with organizations like ASHE, making individuals aware of it, would be very important. That's why they have these types of conferences and resources. So definitely one of the top places I'd go to.
First thing you have to decide is, or determine is this a behavioral health unit? If it is an inpatient behavioral health unit, then the answer is yes. You have to bring it to that standard. If this is not a behavioral health unit, you have some other options. But you have to first find out what it is. So if it's a designated geriatric behavioral health unit, yes, you need to bring it to that standard.
And if I can add too, for geriatric psych, we are well aware that there are specific needs for that population. And again, that goes down to the documentation and mitigating. I always ran geriatric units as part of my programs, and we always had medical beds because of fall risks and skin breakdown and so forth. And so we are not going to prevent you from doing that and having that equipment available for your patients. But again, it's understanding those risks and mitigating. How are you addressing, because there are suicidal patients who are on geriatric units. And so how are you identifying those patients throughout that hospitalization and properly clinically mitigating that risk?
A couple, two comments on this as well. First, remember that patient populations are not monolithic. You can't just say, well, this is a X unit and every patient on this unit is going to be that way. So they're not monolithic. And the second thing to remember is shift. You assess this unit today and say, well, it's Geri Psych, they're non-suicidal, this is who we are today. A year from now, it's highly likely that patient population will have shifted in some way, and you should do another risk assessment, because there's always this shift or creep that goes on in your admissions policies, in your community. So don't be complacent on this. Do more risk assessments, especially if you've reached a conclusion that this is not our problem. Well, it might not be your problem today. You might be a Holiday Inn Express today, but a year and a half from now, your community, your patients, your population will have shifted a little bit, and you have a risk and an exposure there. Reassess yourself.
Solid monolithic ceilings, period, are required in a patient room and patient bathroom within that patient room. When we get out to the other areas, such as the corridors, the common spaces, the common rooms, there are some exemptions that we can use. And we allow for certain mitigation strategies, and clips is one of them. The challenge with the clips, and I'm sure David can speak to this even more, is you have to have that maintenance strategy for it. I have heard feedback that these themselves can become a hazard within the environment because they can fall out. But if you have a successful maintenance strategy and you're monitoring that, and you have a system of checks and balances. I'm working with an organization right now where we talk about an above ceiling permit work order system when it comes to life safety code. Well, what if we had a permit system when I'm doing work in a behavioral healthcare environment, that there's a system of checks and balances after some type of work is done? Did they put the tamper-proof screws in? But again, the clips, it is one of the recommended, but you have to have that maintenance strategy.
And the Joint Commission will be publishing something more on clips. Right now, we are looking at that in particular, and using our data when we go out on survey and seeing the different kinds of clips that are out there and how successful they have been used. We just came out with a bunch of frequently asked questions in our July perspectives, and that's on the list of our next run of frequently asked questions, but we need to do some thoughtful analysis of it.
I think if you or I were sitting down having a beer, I'd probably say to you, I wish we could call Doug Erickson right now, because I think FGI is probably on the bleeding edge of a consensus standard for behavioral health. They've got a whole chapter there. In fact, the whole idea of risk assessment really started with something that was embedded in one of the FGI editions. So some large number of states have adopted that, so the authorities having jurisdiction can refer to that. But you're right. Neither New York State nor the Behavioral Health Design Guide from Jim Hunt is a consensus standard. I like what FGI has got going right now. There are a lot of thoughtful people put a lot of time and energy into that, and it changes over time. So as the patient populations change and our thinking about this issue change, it tries to keep up. But great question. Thank you.
I'd like to thank our panel. Again, they are not speaking for or against any particular product or for their organization, but sharing their thoughts and their experience with what they've been doing. We'll be up here for a few minutes. If you have a question, enjoy the rest of the conference and make use of the resources here. Thank you.
Thank you.